Dr. Christopher McDougall received a BA in chemistry from Fraser University and an MD from Indiana University School of Medicine. He subsequently completed a residency in psychiatry at Yale University School of Medicine and a fellowship in child and adolescent psychiatry at Yale Child Study Center. Dr. McDougall is an internationally recognized expert in neurobiology and neuropsychopharmacology of childhood-onset neuropsychiatric disorders, including autism spectrum disorder. His interests also include the etiology and pathophysiology of syndromes associated with intellectual disability. Please help me give a warm welcome to Dr. Christopher McDougall.
Hello to everybody. Well, next slide, please. These are conflicts of interest that I may have. I consult to the top two pharmaceutical companies designing studies for research in autism, and I've published 3 or 4 books for Oxford University Press and Springer Publishing. Next slide. Every medicine that I'm going to talk about today is off-label, meaning there are no drugs that are approved by the FDA for use specifically in people with HADDS. Next slide. So when I see a new patient, they come to me for the first time. There are a number of things that we do in order to know what type of symptoms or behaviors we're treating, and if in fact those symptoms need to be treated with a medication or a different therapeutic approach. So we first make a diagnosis, and that's based on me just taking a history, asking the parents about the pregnancy, developmental milestones, current medications, medical problems, family history, and then various symptoms like aggression or self-injury or anxiety or social problems or speech problems or depression, that kind of thing. So we take a history. It's important to do a physical examination because sometimes medical problems can present looking like behavioral or psychiatric problems, and we wouldn't want to treat those with a psychiatric medicine. We'd want to treat the actual medical problem. A review of systems is just asking the parents about possible medical problems from head to toe. So any problems with the ears, with swallowing, with breathing, just go right down the line. Neuropsychological testing is a formal testing done by psychologists where they administer a number of tests to try to determine the individual's IQ, their ability to focus and concentrate, and basically the way their brain functions. And family history is important because many of the psychiatric disorders we treat tend to run in families. So once you do this, you have a pretty good idea of diagnosis, the types of symptoms that are problematic, and you begin to thinking about appropriate treatments. Next slide. And these are some of the treatments we think about. So about behavior therapy. One form is called ABA, Applied Behavior Analysis. Speech and language therapy is very important if that's an issue. Occupational therapy is helpful for fine motor control problems or sensory issues, feeding difficulties. Physical therapy is helpful if there are problems with walking or gross motor problems. It's important to think about the appropriate educational placement, whether the individual is on a more standard academic track or a track designed to help them with activities of daily living, life skills. And if the person's in the wrong educational setting, that can lead to all kinds of behavioral problems that you wouldn't necessarily address with a medicine. You'd address it by trying to find the most appropriate educational placement. As I mentioned before, we want to identify any underlying medical problems and treat those. And then finally, pharmacotherapy, which is the use of medicines to treat behavioral symptoms, is something I have expertise in, and that can be very helpful. Next slide. So what are the kinds of symptoms, if you will, that may be present in people with HADDS that might warrant treatment with a medicine? Well, speech and language. Certainly you use speech therapy, but I'm going to talk to you a little bit about a medicine that you could use. Sleep problems, ADHD, autism, anxiety, symptoms of irritability, which include aggression toward others, self-injury, or severe tantruming. So people with HADDS may present with all of these, none of these, more likely some of these. Next slide. Let's start with speech and language. Next slide. So certainly we want to implement formal speech therapy if that's an issue. There really aren't many drugs or medicines to help enhance speech, but this is one thing to know about and to think about and look into. So folinic acid is just a natural vitamin, but it's also marketed as a medication. And as a medication, it's called leucovorin, Leucovorin. And there have been studies in kids with autism who have trouble speaking with folinic acid, and it can improve expressive language in people where that's an issue. And it's a very safe medicine. There are no serious side effects. So if your person has difficulty with expressive language, this is something you might want to look into and bring to the attention of your prescriber for consideration. Next slide. What about the treatment of insomnia or sleep problems? Well, at least in people I treat, sleep problems are a big issue. You know, if the person isn't sleeping well, then their behavior is not going to be very good the next day. If the person isn't sleeping well, other people in the house, like siblings and parents, aren't sleeping very well. So this is not a minor issue. And this is sort of the order in which I think about medicines for sleep. If sleep disturbance is interfering and you've tried non-medication approaches and they haven't helped enough, you might want to think about melatonin. Melatonin is a normal hormone that's in all of our bodies, but you can also give it as a drug. Melatonin is very safe, despite what you might hear or read about. That it's very well tolerated. And I encourage people to go to the drugstore and buy melatonin over the counter. And I encourage them to buy 3 milligram pill strength. And if I give it every night for a week, and if things aren't better, I give 6 milligrams every night for a week. If that doesn't help, 9 milligrams per night for a week. And then if that doesn't help, then melatonin isn't going to work. The most melatonin we ever use is 10 milligrams at night, but that's where you want to start. If melatonin isn't helpful, then a drug called trazodone, which was called Desiril back in the 80s when it was marketed for the treatment of depression. Well, we don't use it to treat depression because it causes too much sleepiness. So instead, we use it to treat sleep problems. And it's probably my most consistently effective medicine for sleep problems. If I could only have one to use, I would pick trazodone. What are the side effects? Well, it can cause sleepiness. That's what you want. And in rare cases, it could cause something called priapism, and that is a penile erection that can last a long time, like up to 4 hours. And if that's occurring, then the person needs to go to the emergency room. Now, it's rare. It doesn't stop me from using this medicine, but I would mention it to the parents of a adolescent or adult male that I'm treating to say you need to be aware that this could happen, because if the individual is cognitively impaired or has trouble communicating, they may not be able to bring this to your attention. Clonidine is another medicine that can be used for sleep. It's an old medicine that used to be used to treat high blood pressure. So it can lower your blood pressure or your heart rate, although in the doses that we tend to use, that doesn't occur. One challenge with clonidine is it often helps people fall asleep, but over time, I find that they may develop a tolerance to it. So they start waking up in the middle of the night and may need another dose. So that isn't an ideal setting. Mirtazapine or Remeron is an old antidepressant, and it was also too sedating. So we don't use it to treat depression. We use it to treat sleep disturbance. And a little bit later in the talk, I'm going to tell you that we also use this to treat anxiety. So many people who are anxious also have trouble sleeping. So mirtazapine might be a great drug in that situation. Sometimes we use a class of drugs called benzodiazepines, and you've heard of some of these, Xanax or Valium or common trade names, but we tend to use one called Zolpidem, which is Ambien, or lorazepam, which is Ativan. Now, people develop a dependence on these drugs. In other words, they're a habit forming. That doesn't mean they're addicting or that you need more of it over time. It means that if you're on it, you don't want to stop it abruptly, or you could have withdrawal symptoms. And rarely do we use Benadryl or hydroxyzine, but on occasion. Next slide. What about the treatment of ADHD? Next slide. Well, we know ADHD is a very common childhood onset disorder. And if you're treating individuals who are more neurotypical, who just have ADHD, and you're going to use a drug, you want to use a drug called a psychostimulant. And there are two different types of psychostimulants. There are the methylphenidate or Ritalin type psychostimulant, and then there's the amphetamine or Adderall-like psychostimulant. And the two categories are very different. If one doesn't work or causes side effects, the other one might work and might not cause side effects. You want to consider a trial from both categories. And these drugs come in short-acting and long-acting formulations. Sometimes with the long-acting formulation, you only have to give it in the morning once a day. That can be a benefit. The good thing about stimulants is they work quickly. You're going to know if it's going to work or cause problems within a few days or a week. What are the main side effects? Well, they can reduce your appetite. So if your person already is very thin and has trouble eating, it may not be a great drug. These drugs can also cause trouble with sleep, but that's usually only if you give the drugs too late during the day, right? You need to give them in the morning and in the afternoon. Tics, which are abnormal involuntary movements like eye blinking or throat clearing or that kind of thing. Sometimes stimulants can cause those. They're reversible. Or if the person has tics, they can make them worse. And sometimes stimulants, particularly in people with neurodevelopmental disorders or developmental disorders like HADDS, stimulants can actually make the person worse, more irritable and anxious. So these drugs don't work as well in people with developmental disorders as they do in people, more neurotypical people who just have ADHD. You may need to give these drugs more than once a day. If you're able to swallow a pill, then you can take the extended release form and just take it in the morning. But many people I treat can't swallow pills. The other thing is these are controlled drugs, meaning we don't want just anybody to have these, right? We want to have them used for the right purpose. So for that reason, you can't give any refills when you write a prescription. You have to give a new prescription every month. Next slide. Another treatment for ADHD, if stimulants don't work or cause problems, are alpha-2 agonists. And again, these are drugs that historically were used to treat high blood pressure. So they can reduce your blood pressure and your heart rate, but they usually don't in the doses we use. So the drugs are guanfacine, and the trade name of that is 10X, or clonidine, which is Catapress. These drugs can also be sedating. The goal isn't to make the person's ADHD better by putting them to sleep. It's by treating their ADHD. So sedation could be a problem. It doesn't usually isn't a problem if you start at a low dose and you go up slowly. It's important to know that these drugs can cause constipation, although that isn't common. Unlike stimulants, these medicines are not going to make the person worse. They're either going to help or do nothing. If it's a short-acting form of the drug, you may need to give it 2 or 3 times a day, but there are long-acting forms. The long-acting form of guanfacine is called Intuniv, once a day in the morning, but the person, again, has to be able to swallow the entire pill or capsule. Next slide. The final drug treatment option for ADHD would be atomoxetine or Strattera. This is a drug that works by increasing brain norepinephrine. There's evidence that it works for ADHD when that's seen in people with autism. And this drug, as compared to a stimulant, which can work quickly, this is going to take some time. You have to start at a very low dose, go up gradually. So it may take 3 or 4 or 6 weeks before you see a full improvement. Next slide. What about autism spectrum disorder, or autism? Well, that's what I do for a living. I don't know the percentage of people with HADDS that have autism as well. I imagine some of the people with HADDS have some of the symptoms or traits of autism. And what are those? Well, people with autism struggle with social communication. They may have trouble communicating. They may not talk at all. They may be minimally verbal. And then they will have trouble with social interaction. They may not know how to initiate social interaction or how to carry on a conversation. They may not know what appropriate social behavior is. So that's always there in autism. And then people with autism are going to have repetitive behavior. That might be hand flapping or rocking or lining things up or spinning things. If they're verbal, the person, they may engage in repetitive questioning over and over and over, even if they know the answer. So if your person has these kinds of symptoms, you'd kind of wonder, do they have autism or do they have traits that are common in autism? Next slide. What about anxiety? Well, my guess is that everybody with HADDS has some anxiety. Certainly everybody with autism does. And but it's important to understand what anxiety looks like in people with neurodevelopmental disorders. It may look different than it does in you or me. Next slide. So these are the kinds of things we see if the person has anxiety. They may pace a lot, pace back and forth, or pace around the perimeter of the house. They may become anxious and run away, dart away. They may bite their fingernails or pick at them. This is something I always ask people to do. Hold out your hands. And if I see Band-Aids on the fingernails or evidence of, fingernails being bitten or picked, that's definitely anxiety. If the person asks the same question over and over, even though they know the answer, that's anxiety. If they rock or flap their hands or jump up and down or rock, that can be anxiety. If they talk about the same thing over and over, like a Disney movie, and they just repeat the statements, the scripting over and over, that could be anxiety. If they talk to themselves Well, people with developmental disabilities, when they're talking and nobody's there, it doesn't mean they're hallucinating. They're not talking to somebody else. They're talking to themselves, and they might be saying things like, don't do that, do a better job, things that a parent might say to them, and they might be trying to help themselves by talking to themselves. Sometimes people who are anxious will become more quiet and isolate. Anxiety can cause sleep problems. It can cause temper tantrums or meltdowns. Next slide. So what about medicines for anxiety? Again, I think because your people are probably, most of them have anxiety. Well, if it's interfering and you're going to use a medicine, these are the ones you should be using. So the first one is called buspirone. The trade name is Buspar. It's been around since the 80s for the treatment of anxiety. You could say, well, why haven't I heard about that? Why aren't I taking it? Because it doesn't work for neurotypical people for anxiety. It works for people with developmental disorders. That's just the way it is. Their brains are different. I mentioned mirtazapine earlier, or Remeron. It's another good medicine that for anxiety in people with developmental disorders. Now, we wouldn't use it to treat anxiety or you or me because it doesn't work. And it can cause increased appetite and weight gain, but not always. But you need to watch for that. And as I mentioned before, it can cause some sedation. So we only give this at bedtime, but many people with anxiety are also need a medicine for sleep. What's an SSRI, a selective serotonin reuptake inhibitor? And next slide, I think. Now go back. I'm sorry, go back where I was. So SSRIs, you know about drugs like Prozac, Zoloft, Paxil, Lexapro. These are drugs that you take if you have anxiety or depression. But when we give these medicines to people with disabilities, they often make them worse, more anxious, more irritable. So it's rare that I ever prescribe an SSRI in my clinical work. Next slide. Here's a result from a study of Buspar for anxiety in kids with autism. It was 8 weeks long, 22 subjects, and they were trying to treat anxiety or irritability. Next slide. Well, they started at 5 milligrams 3 times a day. My starting dose is a lot lower than that. So it comes in a 5 milligram tablet, and I start with a half a tablet in the morning for a week, 2.5 milligrams a day for a week. And I go up by only 2.5 milligrams every week, giving it in the morning or when they get home from school. And a typical dose that a person might end up on is 15 milligrams twice a day. You can give up to 60 milligrams a day, but usually people get better on 7.5 or 10 twice a day or 15 twice a day. But in this study, 9 of the 16 subjects had a marked response and 7 others did quite well with very few side effects. Next slide. This is this medicine, mirtazapine or Remeron, I mentioned earlier for anxiety. This is a study we did, and it was a 10-week study where the person either received mirtazapine or placebo, and they didn't know what they were going to get. And if you look at the red line, that's the drop in anxiety with mirtazapine versus the drop in anxiety with placebo. Placebo can result in some improvement, but not as much as the drug. And there was no difference in side effects between the drug and placebo. Again, with regard to dosing, the maximum daily dose of mirtazapine is 45 milligrams. I start at 3.75 milligrams at bedtime, and I go up by that amount each week until they're better, or we have side effects, or they reach 45 milligrams. Next slide. These are the SSRIs that I mentioned earlier. And again, these are what you take, what I take for anxiety or depression, but they often make people with disabilities worse. So I rarely use these drugs. Next slide. A little bit more on SSRIs. If you're going to use them, they tend to be better tolerated and more effective in people who have already gone through puberty rather than those who are prepubertal. Some of the side effects that can cause some insomnia or behavioral worsening. Usually you can give an SSRI once a day. And any antidepressant, you always need to be aware that it can cause increased suicidal thinking, although that's not common. But you need to be mindful of it. Next slide.
Play game while this is going.
What about irritability?
I am playing a game while this is going
on. I treat severe irritability all day long. And that means aggression toward others, self-injury, severe tantruming, property destruction. That's what irritability is. Next slide. And if it's severe irritability that's interfering, you may end up on one of these drugs. They're called atypical antipsychotics. It doesn't mean the person's psychotic. It means that drugs that treat psychosis also treat irritability. And you've heard of some of these. Your person may be on them. Risperdal, Abilify, Zyprexa, Seroquel, Geodon. And I'm going to talk about each of these a little bit. Next slide. So risperidone is very well studied in children, adolescents, and adults with autism. It works very well for serious aggression, self-injury, severe tantruming. But it's a serious drug. You have to use serious drugs if you're going to treat serious symptoms. Drugs that don't have side effects do not treat self-injury or severe aggression. You have to use a drug that's got some power to it. So some of the side effects you might see, it could increase appetite and cause significant weight gain. That's common. It could cause some sleepiness, although that usually wears off. But a common side effect is increased appetite and weight gain that could be pretty significant. Next slide. Aripiprazole or Abilify is the other drug that's FDA approved, like risperidone, for the treatment of irritability in autism. And it can be very effective also. You don't want to start at a high dose here. With aripiprazole, you never, ever want to start with a dose higher than 1 or 2 milligrams a day. And the daily maximum is 30. If you start too high, the person's going to become more restless and agitated. And that's a problem because you don't know if that's a side effect or if you need to go higher on the drug because their symptoms aren't better. Next slide. Olanzapine or Zyprexa hasn't been very well studied for irritability and developmental disabilities. And this is one that can really increase appetite and weight. So it's rare that we prescribe this one. Next slide. Quetiapine or Seroquel, also there are no good studies, but it can be helpful if the other ones aren't helpful. Again, with any medicine you're going to use for people with HADDS, you want to always start very low and increase the dosage slowly. You don't want the doctor prescribing it like he would for people that don't have a developmental disability. You have to tell them to start really, really low and go up slowly. Next slide. Geodon or ziprasidone is the antipsychotic that's least likely to cause increased appetite and weight, which could be important. It can do that, but much less likely. The thing to be aware of with ziprasidone is you don't want to use it to treat people that have heart problems because it can make heart problems worse. So if your person has heart problems, you don't want to think about Geodon. Next slide. Okay, so one thing that Mallory said to me is, she said, you know, people with HADDS are starting to get older. So people are wondering, how do we treat psychiatric problems in older people with HADDS, adolescents and young adults? Well, the thing that's important there is that once you become a late adolescent or an early adult, you're at risk of developing major psychiatric disorders that begin in late adolescence or early adulthood, right? So in me and you, we can become depressed when we reach that age. So having HADDS doesn't protect you from having depression. And you could say, well, how do I know if they're depressed? What if they can't tell me how they feel? Well, if you're depressed, you probably are going to start sleeping a whole lot more or a whole lot less. You're probably going to have reduced appetite or a significant increase in appetite. You're probably not going to want to do things that you normally do that bring you pleasure. So those are the kind of things that might signal depression if the person isn't able to tell you how they feel. The next disorder to be aware of is bipolar disorder, right? That's also the same thing as manic depressive disorder. So severe mood swings from depression to mania. Well, what's mania? Well, if you're manic, you're really revved up. You're talking a lot. You're not sleeping. You have lots of energy. You don't feel the need to sleep. You're not tired. So it's pretty easy to identify if somebody goes from normal to manic. But you're going to need to use a drug that stabilizes mood stabilizers if your person develops bipolar disorder. And what about schizophrenia? That's kind of scary, right? That's a psychotic disorder. That means the person's hallucinating, hearing things that aren't there, seeing things that aren't there, having thoughts or paranoia that's not based in reality. But your people are going to be they can also develop schizophrenia, which also occurs in late adolescence or early adulthood. Now, I doubt if people with HADDS are more likely to develop these things, but they're probably as likely to develop them as you and me, but they may be harder to diagnose, right? Because the person might not be able to say, well, I feel depressed, or I'm thinking the CIA's after me, or something like that. So you have to really know what you're doing as a clinician to make these diagnoses in a person with a neurodevelopmental disorder, particularly those that have cognitive impairment or have difficulty communicating. Next slide. Well, this is just a little bit about the Lurie Center for Autism. So we don't just take care of people with autism, we take care of people with any neurodevelopmental disorder. We treat lots of people that have Down syndrome, Williams syndrome, Angelman syndrome. I can't say I've ever seen a patient with HADDS come to us, but I'm more than happy to see one if they need to see me. So two things make the Lurie Center unique. One is we take care of people from birth to death. We don't just take care of you until you're 22 and then tell you you have to leave. We take care of you until you're 100. And that's pretty unusual to find a place that treats developmental disabilities from birth to death. The other thing that makes us unique is we have all these doctors. We don't just have psychiatrists. We have psychiatrists, neurologists, primary care doctors, gastroenterologists, medical geneticists, developmental pediatricians, neuropsychologists. We try to treat every kind of problem that a person with a neurodevelopmental disorder might develop, not just behavior problems. And that's a picture there of the original Massachusetts General Hospital, which began in 1811. So it's a powerful hospital, Mass General, and we're a Mass General clinic. We're actually based in Lexington, Massachusetts, where the Revolutionary War happened, right? Well, why aren't you in downtown Boston? Because it's too hard to get to downtown Boston and figure out where you're at for you guys. So you get to come and see us at the Lurie Center, which is a very mellow, laid back, easy to manage setting. Next slide. Well, I'm going to ask people to ask me questions. I need somebody that's able to tell me the question so that I can hear it. So I may not be able to hear it from the audience. You might have to repeat it, but let's go ahead and try to do that.
I have a question. Can you hear me?
I can hear you.
Oh, okay. My name is Fernanda, and my son is 3. And I'm curious about the folinic. Is it folinic acid? The
Folinic
one
acid,
for
yeah.
for the communication and
Yeah,
speech.
yeah.
Because I tried to talk to his PCP, and she was like, I'm confused about if this is something over the counter or if it's something that we need to send to a special place to make it, or like to compound. If
Yeah.
there's
I
some
got
like,
you.
or who will be the doctor to prescribe as a specialist?
It's not over the counter. It's a prescription medicine. And usually we begin at a dosage of 25 milligrams in the morning. After a couple of weeks, you could increase it to 25 milligrams twice a day. That's the maximum dose a day, 50 milligrams. You can start lower than that. It may come in, for example, a 10 milligram. Well, you know, if your child is 3 and if they can't swallow pills, you might need a pharmacy to compound it, as you said. And I would probably get it compounded into a liquid where you could begin as low as 5 milligrams a day and then go up by, say, 5 milligrams per week as necessary, or to a maximum daily dose of 50 milligrams. And you want to break the dose into twice a day. So that's how they would prescribe it.
And would be like his PCP, like regular PCP that would prescribe it, or
Well,
needs
you know,
to be another specialty?
That's hard to know, because a lot of PCPs might say, hey, that's out of my comfort zone, right? A lot of PCPs won't prescribe any of the drugs I prescribe. So you could try it. And if they say, like, I don't know anything about it, well, then get them a copy of that scientific article that I referenced on that slide, and they can read that so that they have more confidence in the potential effectiveness and safety of the drug.
Okay, thank you.
Okay.
Hi, Dr. McDougall. My name is Karen. I am a speech pathologist, and I have a follow-up question about the folinic acid. When you say you are seeing increases in expressive language, is that based on like mean length of utterance, or is that based on expectations for chronological age? What are the increases that you're seeing?
Yeah. Well, it depends on what the person is doing at baseline, right? If they're having phrases, let's say, short phrases, they may speak in longer phrases. They may, if they're minimally verbal and they just have a single words or syllables, you know, they may show a little bit of progress in those areas. So it's not going to be dramatic. And I think it needs to be done in conjunction with what you do. But the two together might allow for the process to move forward more quickly. But it's been studied in a placebo-controlled manner, meaning people, half of them get the drug and half get placebo, and we don't know what they're getting, nor do the parents. But it seems like those that get the medicine are more likely to show improvement than with placebo, suggesting there might be something to it. You know, you never know if the medicine is helping to accelerate things or if it's just normal development, like you said. But in the studies, the pace of improvement has been a bit quicker than normal development. But this is still pretty early in the game with this drug. But because of the safety, I think it's something the person might consider.
Thank you.
Sure.
We have a question from the chat and virtual audience. It says from Jen. For example, our daughter is on mirtazapine, clonidine, short-acting, cyprobenzaprine. I'm botching these. I'm so sorry. And methylphenidate. Yet there are still symptoms that all of these issues we are trying to treat. When do we know we've hit the best we can expect from these meds?
All right, so that sounds like a complicated question. I didn't really hear you. I'll tell you what I heard. I think the person's on mirtazapine, clonidine, and methylphenidate. Anything else they're on?
Cyprophentidine,
Cyproheptadine?
heptadine, yes.
Okay, so they're on a lot of stuff, right? And they're on drugs that could be being used for all kind of different things, right? Could be sleep disturbance, anxiety, ADHD. Cyproheptadine is a drug that's used to increase appetite. So it's hard to know what the doctor is treating. It's hard to know how long they've been on each drug. It's hard to know what the dosages are. But all of those things I'd need to know, right? In order to say, well, you just need a higher dose. You need to be on it longer. Or I might say, why are you on two drugs that do the same thing? You see what I mean? So it's not an easy question to answer. But that's probably the best I can do unless they ask a very specific question.
Thank you.
Hi,
Oh, sorry.
my name is Michelle. My daughter Isla, of course. I have a question. It's another question about the folinic acid study affecting speech. I have done folinic acid off and on. I do see currently she's nonverbal, and but she sings and you could hear words. It's still very unclear, but she sings a lot. She laughs great. But when I've given her the folinic acid off and on, she has had increased singing, and the verbalizations are more, they're just more noticeable. You can almost make words out of them. However, my question is, when they did this folinic acid study, is the baseline folate normal or is it low? Because my daughter has actually always had low folate, and she eats a great diet. Sorry.
Yeah, I understand. So you're kind of saying, is there any biological test you can do at baseline that might tell you that there's a need for folinic acid, something like that?
Yes, but did the study have a baseline folate level?
Well, I'm going to tell you. I don't believe they measured folate at baseline, but I'm not positive. You could read the study to see. What the main biological thing that is involved with folinic acid. Some people have antibodies in their body that block the folate receptor. So hang in there with me now. So the folate receptor is on the blood-brain barrier. So what that does is folinic acid's going around in your blood. It binds to the folate receptor, and then it gets flipped into the brain. But if you have antibodies in your blood, they might block that receptor so that folate can't get brought into the brain, right? And it seems like people that have these antibodies are more likely to respond to folinic acid. And they did measure these antibodies at baseline to see if those with the antibodies were more likely to respond than those without. But, separating the science from practicality, I don't think you need any of those tests to know what to do. You just need to try the medicine and see what happens. At this point, the science isn't far enough along where we can say, get this blood test first, and then we know what your chance of getting better is.
Thank you very much.
Sure.
All right, we have another virtual question from Devin Eakins. I have a question. She has 2 children with HADDS. They've arrived at similar medicines to treat their symptoms. For irritability, one is on risperidone and the other is on Abilify. Drooling is a side effect of my son on risperidone. Would it be unwise to migrate to Abilify to avoid that symptom? Is it generally an inferior medication to address irritability and aggression in this situation?
Okay, I think the first question has to do with drooling on risperidone.
That's
Well,
right.
if the risperidone is helpful and you really like it, if the drooling was stopped, you just need to prescribe a drug to treat the drooling. And we have one that's very effective. It's called glycopyrrolate, like GLYCOPYRROLATE or something, glycopyrrolate. And it comes in different doses. You'd start at the lowest one and go up as you need to. But we use that all the time, and it can be very, very helpful for drooling. I think the other question might have been like, which one is more effective, risperidone or Abilify? Does that sound right?
Yes. Mhm.
Okay. Well, they can be equally effective because it just depends on the individual patient. You know, if you said to me, well, what if you could only have one of them for the rest of your career? Right? I'd say I'll take risperidone. But the reason I'm doing that is because I have confidence that it can treat severe irritability fast. I have more confidence. So if the irritability or self-injury or aggression needs to be treated right now, or we're going to end up in the hospital, I'll take risperidone. I think it works more quickly and consistently.
Awesome. She says thank you. She'll look into that with her doctor. Appreciate it.
Excuse me, doctor, this is Jen. I submitted the question earlier online with the list of all the medications my daughter is on. And I think the first part of my question got cut off, but it basically is, how do you know when you've gone as far as you can with medication to manage symptoms and that the remaining impulsivity, anxiety, low appetite, etc., aren't going to be any better with any additional medication? That just is who the child is or what you've got. Like, just in general, how do you know when to stop seeking additional assistance from medication and just dealing with what is?
Well, here's the way I do it. If somebody comes to see me, I'm going to try to determine which behavioral symptom is the most interfering. And I'm going to try to go after only one thing at a time. So let's say it was ADHD, just to make that up. And let's say we tried generic Ritalin and it made the child worse and we had to stop it. Okay. Then I'm going to try guanfacine or 10X. And let's say that helped quite a bit and didn't have side effects. But you said, I think it's working 43% better. And somebody else that lives in your house says, no, I think it's working 45%. What I would, and then you both would say to me, but I'm not sure it's working. If you're not sure a drug is working or not, it's not working and it needs to be stopped. So some people are like, well, I think it's helping some. And I'll say, well, are you sure? And they're like, well, I'm not sure. I said, it's not working. So get rid of it, because that's how drugs get added on top of one another. So you start a drug and it either has to be really working or you get rid of it. So if I got ADHD a lot better, then I'm going to see what's left over. Now I got anxiety. I'm going to start Buspar or mirtazapine, and I'm going to go up on it until the anxiety is better or we get side effects. The one thing you always want to know with a drug is you always want to give it as much of it as you can before you stop it. You don't want to wonder later, gee, I wonder what would have happened if we would have gone up higher if there weren't side effects. So you want to maximize the dose and the duration. You don't want to give it too short a time if there aren't side effects. So I think you kind of get what I'm saying. In other words, I would look at all the drugs the person's on at the dosage. And I'd say, well, there's more dose we could go up. So I'm not going to give up yet and just say we can't do any better.
Okay, and then until maybe you hit the point where the side effect is too much, that it's not benefiting anymore, or it's too unable, you can't handle the side effect, right?
Right.
Okay. Okay, thank you.
Okay.
I have a question. Can you elaborate on what the symptoms in ADHD are best addressed by the non-stimulant medications you mentioned? I'm specifically wondering about impulsivity.
Sure. So by far the best drug for ADHD is a stimulant. However, that's true, and I'm calling it neurotypical ADHD if I can. In ADHD associated with the developmental disability, if a stimulant works, it's still the best one if you can tolerate it. So, if you start low and you go up gradually and you don't get side effects and you get lucky, it's better than a non-stimulant for hyperactivity, impulsivity, and inattention. Now, if you run into trouble and you have to go to a non-stimulant, the non-stimulants are pretty good for hyperactivity and impulsivity. They're not as good as a stimulant for inattention, but you should be able to get impulsivity better if it's truly just a symptom of ADHD and not a symptom of some other disorder.
Thank you.
Excellent. Well, thank you so much, Dr. McDougall, for joining us. I think we all are a lot more knowledgeable and appreciate your time and attention to us, especially addressing the last section about HADDS and kind of our aging population.
Well, thank you. I enjoyed it. I appreciate everybody's attention and questions and the opportunity, and we'll see you later.
All right, take care. Thank you.